It is unique to Madhya Pradesh that sickle cell disease is extremely highly prevalent in this state and in Chhattisgarh. And we as hemato-oncologists and hematologists should actually address this issue. So I'm glad that we are able to get so many of you together from Indore, Bhopal, Riva, Jhabua also, and so on. And thank you very much for sparing your time this evening. And this is on behalf of Teenage and Young Adult Cancer Foundation, which we do in addition to doing medical oncology at Sri Aurobindo Institute of Medical Sciences. And I must thank Novartis for supporting this symposium, because we need basically the know-how, the support, and the methods of outreach to the periphery of the state, so that we're able to reach the underserved population. And as you know, there are 9 lakh homozygous individuals, so maybe more. It's about 10-year-old data that I'm quoting. So obviously, there are a large number of needy patients who are sickle cell affected, and they need some kind of care. And we need to create a system. And so thank you very much for joining this. And I will now hand over the mic to Dr. Shivani to take the proceedings forward, to introduce the subject and so on.
Thank you very much, sir, for inviting today. And I think it's a very great initiative. I have worked with you, and I know how passionate you are about the disease. And finally, we have to it, and we are able to gather people in Pradesh and talk about this unique disease. So today I'll be speaking on the diagnosis and management of the sickle cell disease. This is the overview of my presentation. We'll be talking about diagnosis at different stages of life, and various sickle cell syndrome, and the general management. The management of various crises will be discussed by my colleague Dr. Swati. So sickle cell disease, as we all know, it has a very varied presentation and clinical features. It can be asymptomatic to it can present to an extent that it can present as a life-threatening situation when they come in crisis. And similarly, we have various method of diagnosis at different age group. So all the high-risk couples should be screened for presence of the carrier status, and prenatal diagnostic testing should be advised. We can test this disease in fetus by invasive or non-invasive methods, and the sample is obtained by either of the method, like chorion villus sampling, amniocentesis or chordosynthesis, depending on the gestational age. The fetal DNA is then processed for the genetic mutation of sickle cell disease, and the couple can be given an option for termination if they give consent, or if the baby is not carrying the genetic mutation, then pregnancy can be taken forward. Another important step is the newborn screening. So a lot of countries have a universal and mandatory newborn screening in place for sickle cell disease. It is yet not universal and mandatory in our country, and it can be done through a heel prick or a cord blood sample. The sample is taken as a dried blood spot on a filter paper, and it is processed through one of the methods. And in our country, the most commonly used method is hemoglobin electrophoresis. So we get various patterns. Sickle cell is a variant hemoglobin, so it can be diagnosed during the newborn age. We get various pattern on newborn screening, either FS or FSA. Depending on that, we can say whether it is a homozygous sickle cell, or sickle beta thalassemia, or a sickle heterozygous with a variant hemoglobin like HPD Punjab. So any abnormal screening during the newborn period should be confirmed by a repeat sample. All the new should be put who have been tested positive for sickle cell newborn screening should be started on penicillin prophylaxis, and all this result are rechecked at 6 months of age and later with the hemoglobin electrophoresis to confirm the diagnosis. In older children, it present in a very different way. We can get a diagnostic clues based on a simple complete blood examination and peripheral smear examination. So sickle hemoglobin, the lifespan of sickled RBC is less. So there is always an intravascular and extravascular hemolysis going on in their body. So they'll present with mild to moderate anemia with reticulocytosis. MCV is usually normal. On peripheral smear, you'll see normochromic, normocytic RBCs. If there is low, the indices are low, then a concomitant sickle beta thal, alpha thal, or iron deficiency anemia should be suspected. White blood cell is usually normal with normal differential count, but during the crisis or any infection, they can have neutrophilic leukocytosis. And on peripheral smear, we can see sickled RBCs, polychromasia, which is a sign of hemolysis, and Howell Jolly bodies as they have functional asthenia. They'll have elevated LDH and indirect hyperbilirubinemia, which is a marker of hemolysis. So in community, we can do screening test to detect the presence of sickle hemoglobin. It can be either done through a sickling test or a solubility test. In sickling test, we induced sickling in the RBCs with the help of sodium metabisulfite and examine the slide under the microscope. Similarly, solubility test is based on the principle that hemoglobin S is insoluble in high molarity phosphate buffer, but in these tests cannot differentiate between various sickle syndrome and sickle cell trait. So hemoglobin electrophoresis is a confirmatory test which is used most commonly and easily available. In homozygous sickle cell, HbS percentage will be more than 50% and HbF will be less than 50%. But it has to be done before blood transfusion. Post blood transfusion, the results cannot be interpreted properly. And in such conditions, when the transfusion has already been given, we can confirm the diagnosis using the genetic DNA sequencing. So sickle cell phenotype encompasses a lot of different variants and different genotypes, which can present as similar to sickle cell phenotype. It includes sickle homozygous, sickle beta thalassemia, sickle cell with hemoglobin C, sickle cell with hemoglobin D Punjab, and all these syndromes we can diagnose based on the hemoglobin electrophoresis. So management of sickle cell disease in general, it is very, very important that once the diagnosis, usually we see this patient only when they have a crisis or some life-threatening problem. It is very, very important to have a routine health visit with a pediatrician or hematologist. And our aim should be prevention of these crises, which is very easily preventable with hydroxyurea, instituting correct infection prevention measures, routine monitoring of the chronic complication and organ damage. And the most important thing which we should all focus on is the genetic counseling. This is a genetic disease and it's a preventable disease. So each and every family or the individual should be counseled for the prenatal testing so that we can prevent further birth of the disease. And the extended family members who are of reproductive age group should undergo the screening test. So when we say talk about routine health maintenance, so any newborn who's have been diagnosed as positive during newborn screening should be referred once a diagnosis confirmation is made and started on penicillin prophylaxis. So during first year of the diagnosis, minimum 3 monthly visits are required, and after that it can be 6 monthly based on the patient's presentation. So every visit, physical examination should be done detailed, including blood pressure and saturation monitoring. Testing like a complete blood count with reticulocyte count, HbF percentage, and liver and renal function tests should be done. Growth and development should be monitored during every visit. It is a chronic disease and it does affect a lot of organs and present with organ dysfunction, and various tests should be done to monitor that. So the most important preventive therapy we have for sickle cell anemia is hydroxyurea today. Hydroxyurea was the first approved for prevention of VOC in sickle cell diseases. It acts by a lot of mechanism like increasing fetal hemoglobin, so it decreases sickling and improve the erythrocyte survival. It by reducing the WBC count and adhesiveness of the neutrophil, it decreases the inflammatory response. And it is also a potent, it also releases nitric oxide, which is a potent vasodilator and helps in preventing the recurrent veno-occlusive crisis. It should started to all children more than 9 months of age, and initial starting dose is 15 to 20 milligram per kg per day, and it should be gradually increased every 6 to 8 weeks to a maximum of 35 milligram per day, or the dose is adjusted based on the maximum tolerated dose by monitoring the CBC and liver and renal function. So fetal hemoglobin should be done at the baseline before starting hydroxyurea, and we repeat it every 6 months to see for the response. It should increase with hydroxyurea therapy. If we cannot do fetal hemoglobin, then even MCV is a good indicator of the compliance. Patients on hydroxyurea should have a high MCV. They should have high normal MCV. The dose limiting toxicity is myelosuppression, and hence CBC should be frequently monitored for those who are on hydroxyurea, and it should be withheld if ANC is less than 1500 and platelet count is less than 80,000. So we have a good enough evidence to say that it decreases the rate of veno-occlusive diseases, rate of hospitalization and acute chest syndrome in sickle cell patient. It is a very good safety profile, and it has worked across all age groups. So all the patients of sickle cell disease, as soon as the diagnosis is made, should be started on hydroxyurea. Another important cause of morbidity and mortality in these patients is infections. They have functional hyposplenia and undergo autosplenectomy. Hence, they are susceptible to capsulated organism infection from capsulated organism. So penicillin prophylaxis should be started to all the patient, and it should be continued at least up to the age of 5 years. And they should be vaccinated against all the routine vaccination as per IAP, as well as the invasive capsulated organism. So every organ takes a toll. This disease takes a toll on every organ, and we should be monitoring about the end organ damage. So if we see after 2 years of age, all the children with sickle cell anemia should undergo transcranial Doppler to measure the velocity in the flow velocity in the major artery supplying the brain. If it is more than 200, then it should be confirmed again with a repeat transcranial Doppler after 1 month. If it is persistently more than 200, then these patients are at a very high risk of stroke, and they should be put on chronic transfusion therapy. So to look for sickle cell retinopathy, these children should undergo fundus examination annually starting at the age of 10 years. Renal disease, sickle cell affects the renal system in causing microalbuminuria, proteinuria, and hyperstenuria. So they should have annual urine analysis starting at the age of 10 years, and anytime they develop microalbuminuria, they should be referred to a nephrologist and started on ACE inhibitors. Cardiovascular disease is monitored by regular blood pressure examination. Routine echo and ECG are not recommended in asymptomatic individuals. They are performed only if they have any cardiorespiratory system. So bone mineral density using DEXA scan should be done in these patients after 12 years of age every 2 yearly, and physical examination and X-ray to rule out avascular necrosis of femur, which is a very common complication in these patients. The another important thing is blood transfusion. So we follow restrictive strategy in sickle cell anemia. We do not transfuse if it is not necessary. Should be done only and only if necessary. Routine painful veno-occlusive crisis does not warrant a blood transfusion. Rather, over-transfusion should be avoided in this patient because it can increase the hematocrit and precipitate hyperviscosity syndrome, which will further precipitate the sickling crisis. So we two type of transfusions can be done if it's an acute indication or a chronic or as a part of chronic preventive therapy. Acute indication we do usually to correct the urgent correction of anemia is needed, especially when there's a symptomatic CCF with hypotension, dyspnea. HB have fallen more than 20% from the baseline with symptomatic anemia during aplastic crisis and during acute splenic and hepatic sequestration crisis. Chronic preventive therapy here the goal of transfusion therapy is to keep the hemoglobin sickle hemoglobin percentage less than 30%, and this is used as a primary stroke prevention in those who have transcranial Doppler velocity more than 200 centimeter per second, or those who, despite being on hydroxyurea, are having recurrent acute chest syndrome and significant veno-occlusive crisis affecting their quality of life. Another place where we need transfusions in sickle cell anemia is during certain emergency conditions where we have to rapidly decrease the sickle hemoglobin percentage. It can be achieved either by simple transfusion or by a exchange transfusion. If the hemoglobin is low, we can do simple transfusion and decrease the hemoglobin percentage. But if the hemoglobin is around 9 or 12, 9 or 10, at that time we cannot do simple transfusion in them, and we'll have to go for exchange either manual or through apheresis. So the indications of an emergency transfusion and acute ischemic stroke, acute chest syndrome, multi-organ failure, intrahepatic cholestasis, prior prism more than 4 hours, not responding to pharmacotherapy, and sometimes even in severe sepsis. So bone marrow transplantation or hematopoietic stem cell transplantation is a curative option. And there are certain indications where we will advise bone marrow transplant in some patient. It is not routinely advised in all the patients. If there is a CNS event which is occurred in the patient, if they are more recurrent acute chest syndrome or VOCs despite being on optimal hydroxyurea therapy, if there is any end organ damage like sickle cell nephropathy, retinopathy, or red cell alloimmunization is there, which limits long-term transfusion therapy, then it is indicated. It should be done as early as possible before the major organ damage has occurred, and match sibling donor is the recommended transplant strategy. But in our country, there we have specific challenges. We are still struggling with the routine follow-up and monitoring of the patient, and the compliance of hydroxyurea, and the major challenges with us is availability of donor as well as the cost of transplantation. Thank you.
Thank you, Shivani. I think you brought out one quick question is, tell me about the avascular necrosis of the femoral heads. Do you need MRI or X-ray is actually adequate? Is that
Sir, in very early stages to detect with X-ray is difficult. X-ray findings are usually seen only in the late stages when the mostly femoral head is completely destroyed. So if we patient is presenting with a significant limb pain, hip pain, and we do then MRI is the way for early diagnosis.
absolutely? Thank you very much. I think you covered a lot of ground, and now I'll invite Dr. Swati Patel Jain, who's pediatric hematologist in SAMES, and I would like request her to uh, make a presentation basically on the veno-occlusive crisis, vaso-occlusive crisis. Dr. Swati, please.
Good evening, sir. Good evening, everyone. And thank you for inviting me for this talk. I'll share my screen. So today we'll be discussing about management of crisis in sickle cell disease. So the pathophysiology, first of all, before discussing the crisis, we need to discuss the pathophysiology of the crisis. So in sickle cell disease, there is a mutation in the beta globin gene at the 6th codon where the glutamic acid gets replaced and valine takes its place, and this leads to a propensity of the hemoglobin to polymerize under deoxygenated conditions. So this polymerization leads to sickling of the cells, and this sickling of the cells leads to endothelial damage and endothelial activation and hemolysis of the sickled cells. The hemolysis will further lead to release of free plasma hemoglobin, and this free hemoglobin is very toxic to the endothelium, leads to endothelial damage, endothelial activation, and causes an inflammatory reaction. Along with that, it depletes the nitric oxide and it leads to vasoconstriction. So the entire cascade leads to vascular occlusion, vascular ischemia, and organ ischemia and organ damage. So there is a concept of delay time in sickling, which is the time from the onset of the polymerization to the completion of polymerization of HbS, which ultimately leads to the sickling. So whenever the transit time of the RBC in any vessel, especially in a small caliber vessel, if the transit time is longer than the delay time, then there is a propensity of the RBC to get sickled in that capillary, and it will lead to lodging of the RBC in the microvasculature. So whenever there is any stress in the body, such as mental stress, fear, anxiety, pain, cold, etc., the autonomic nervous system gets activated. It causes vasoconstriction, which increases the transit time. And this transit time, when it is increased, it leads to the lodging of the RBC in the microvasculature. So sickle cell crisis term was coined by Dix in 1965, and it is described as any new syndrome that develops rapidly in patients with sickle cell disease due to inherited abnormality. Mainly, there are three types of crisis: vaso-occlusive crisis, sequestration crisis, and aplastic crisis. There are various manifestations of the vaso-occlusive crisis, which are the painful crisis, acute chest syndrome, acute abdominal pain, acute CNS event, and priapism. In painful crisis, mainly the lower spine, knee, shoulder, elbow, these joints are involved. Sometimes even joint effusion may be seen. And when we have only a single joint involvement, and it greatly mimics osteomyelitis. And the only way to differentiate a single joint involvement from osteomyelitis is when you get a positive blood culture or positive fluid culture. Otherwise, we have to treat along with antibiotics, we have to give hydration and we have to manage both. In children less than 5 years, we get dactylitis, that is the involvement of the small joints of the hands and foot. It is known as hand-foot syndrome, and it is often the first presentation in children less than 5 years. Acute chest syndrome is one of the leading causes of morbidity and mortality in sickle cell anemia. It is most commonly seen in 2 to 4 years of age group. It is diagnosed by two criteria. First of all, a radiographic evidence of any new segmental pulmonary infiltrate, along with one or more of the following, that is fever, tachypnea, cough, new onset hypoxia, increased work of breathing, or chest pain. Often the etiology or trigger is the fat or bone marrow emboli and infections such as bacterial, viral, or mixed infections. Acute abdominal pain can be caused due to multiple conditions like mesenteric sickling, vertebral disease causing nerve compression. It may mimic acute surgical abdomen, and intrahepatic sickling, which presents with fever, jaundice, tender hepatomegaly, and leukocytosis. It can be because of the intrahepatic cholestasis, acute sickle hepatic crisis, or hepatic sequestration. Acute CNS event most commonly occurs between the age of 5 to 10 years, although it can occur from 0 to 20 years, and it results from infarction in the setting of a chronic vasculopathy. If on routine transcranial Doppler, as Dr. Shivani discussed, the middle cerebral artery velocity is more than 200 meter per second, then patients are at a high risk for developing an acute stroke. It can present as hemiparesis, focal seizures, gait dysfunction, and speech defects. Sequestration crisis. Children with SS disease who have yet not undergone autosplenectomy, as well as those with HbSC disease or HbS beta thalassemia, they are prone for sequestration crisis. It is a sudden, rapid, and massive enlargement of spleen, which causes a trapping of a RBC mass. Patient suddenly becomes very weak and dyspneic with rapidly distending abdomen, left-sided abdominal pain, vomiting, and shock. On examination, there will be profound hypotension along with cardiac decompensation and massive splenomegaly. The hemoglobin will fall more than greater than 2 gram per deciliter from baseline. There will be reticulocytosis and there will be thrombocytopenia. Treatment involves simple blood transfusion. However, we must take care that not to over transfuse, as when there is a resolution of the sequestration occurs, this RBC mass which was trapped in the spleen is released back in the circulation, which leads to an increase in the RBC mass, and it can increase the hematocrit and the viscosity. Aplastic crisis is defined as temporary cessation of the bone marrow activity because of suppression by intercurrent bacterial or viral infection. It presents as severe anemia with reticulocytopenia. This is important that normally in sickle cell anemia we get reticulocytosis, but if we are getting severe anemia with reticulocytopenia, we should suspect an aplastic crisis. Parvovirus B19 is commonly implicated, and spontaneous recovery occurs within 7 to 10 days, which is generally heralded by a markedly elevated nucleated RBC count followed by reticulocytosis. Treatment is supportive during this recovery phase. Now, acute management of vaso-occlusive crisis, hydration. The three cornerstones of an acute vaso-occlusive crisis management is hydration, analgesia, and antibiotics. Hydration is given usually as hyperhydration, which is 3000 to 4000 ml per meter square per day. Choice of fluid can be normal saline, dextrose normal saline, or half dextrose normal saline. Oxygenation is required if the SpO2 is less than 95% or if the patient is having acute chest syndrome. Analgesia is very important and it should not be withheld. We can start with paracetamol and NSAIDs, tramadol, and if needed, opioid analgesics can be given, fentanyl, buprenorphine, and morphine. Whenever we are giving analgesia, we should also be precautionate, especially in cases of acute chest syndrome, to prevent respiratory failure. Antibiotics should be started if there's any suspicion of infection, underlying infection. Simple blood transfusion is indicated in acute chest syndrome and priapism. Exchange transfusion is given in acute stroke, acute hepatic cholestasis, and if acute chest syndrome is not responding to simple transfusion, then exchange transfusion can be used. It should be kept in mind that exchange transfusion or simple transfusion should not be used for an acute pain episode or an acute pain crisis. Now, prevention of sickle crisis episodes. The non-pharmacological measures include avoidance of triggers such as pain, dehydration, sepsis, surgery, or emotional stress, prompt treatment of infections and painful crisis, as one crisis, if untreated or if poorly treated, can worsen into another crisis, like a pain crisis can further lead to acute chest syndrome. Chronic transfusions in stroke or whenever there is a high cerebral arterial flow velocities on TCD, such patients should be given chronic transfusions to prevent crisis. Pharmacological measures include hydroxyurea, crizanlizumab, L-glutamine, and voxelotor. So these are the recent drugs in sickle cell disease. Crizanlizumab and L-glutamine act on the vaso-occlusive episodes in sickle cell disease and lead to a reduction in these episodes. Voxelotor decreases the hemolysis. It is a HbS polymer inhibitor, and it decreases the hemolysis and leads to an increase in the hemoglobin levels. Hydroxyurea is being used for sickle cell anemia as early as 1980s, and it is still very effective and one of the most important drugs being used for sickle cell anemia. And it has various mechanisms of action. It increases the HbF synthesis, thereby decreasing the HbS polymerization, decreasing the RBS membrane damage, decreases hemolysis, decreases neutrophil count, so there is decrease in the inflammation, and it increases the hemoglobin synthesis. It also decreases vasoconstriction by releasing nitric oxide, decreasing thrombosis, and decreases the endothelial activation and adhesion. So there is substantial body of evidence from various studies which have shown a benefit of hydroxyurea in reducing the vaso-occlusive crisis, prevention of stroke, rates of hospitalization, rates of acute chest syndrome. Hence, hydroxyurea should be recommended to all patients with sickle cell disease, irrespective of age, to reduce the vaso-occlusive crisis. Challenges in use of hydroxyurea is non-adherence. Not all the patients respond to hydroxyurea, and some patients are intolerant to hydroxyurea. Crizanlizumab is a new drug, which is a monoclonal antibody that binds to P-selectin. P-selectin is expressed in the endothelial lining, and it is involved in the inflammatory response and endothelial activation. So, crizanlizumab, as shown in the SUSTAIN trial, this will be covered by Dr. Chitalkar sir in the upcoming presentations. So, crizanlizumab was used for prevention of pain crisis in sickle cell disease, and it has shown that crizanlizumab at a dose of 5 mg per kg showed significant reduction in the vaso-occlusive crisis and delayed the median time between the first and second vaso-occlusive crisis. As per the Indian guidelines, currently it recommends the use of crizanlizumab to sickle cell disease patients who do not have adequate response or intolerance to hydroxyurea. L-glutamine is a conditionally essential amino acid that is required for synthesis of NAD and glutathione and becomes essential during the oxidative stress exposure. The redox ratio in sickle cell RBCs is lower than normal, hence consistent with the oxidative stress. So oral glutamine increases NAD and glutathione in the RBCs and decreases oxidative stress, thereby leading to decreased sickling and decreased vaso-occlusive crisis. A phase 3 trial of L-glutamine was performed in sickle cell disease, and it was shown that the mean cumulative number of pain crises were lesser in L-glutamine compared to placebo. Time to first sickle cell crisis was lower in delayed in L-glutamine, and time to second sickle cell crisis was also delayed in the L-glutamine compared to placebo. However, there were multiple adverse events recorded, such as constipation, nausea, vomiting, headache, abdominal pain, etc. And long-term safety data are lacking in sickle cell anemia. Pharmaceutical grade L-glutamine has shown some benefit in reduction of vaso-occlusive crisis, but there are challenges, namely availability of long-term safety data, adherence to medication, and currently there is no data in the Indian patients. Uses of L-glutamine may also pose a risk of discontinuation of hydroxyurea, and as of present condition, pharmaceutical grade L-glutamine is not available in India. Hence, this cannot be used in our patients at present. Note about the exchange transfusion in sickle cell disease. In acute crisis, exchange transfusions are used in acute stroke, acute chest syndrome, which are not responding to simple transfusion, acute severe cholestasis, and priapisms not responding to simple transfusions. Exchange transfusions can be automated using an apheresis machine or manual exchange. The total blood volume is calculated as 70 ml per kg in weights above 220 kgs, and in children less than 20 kgs, volume is calculated as 85 ml per kg. The red cell volume is then calculated as total blood volume multiplied by the hematocrit. For an effective red cell exchange, the total volume to be given is 1.5 times the red cell volumes. For manual exchange, alternate equal volumes of packed cell RBCs with fresh frozen plasma or normal saline. In the end, I would like to say that to manage a patient with sickle cell disease, a collaborative effort of multiple disciplines is required, and together we can all participate, and together we can all take care of the children with sickle cell disease, of a disease which is so unique to our own state, and we can help our state in the health sector. Thank you.
Thank you very much. I think you covered a great amount of information, and particularly the crisis management. And yes, we also we touched upon exchange transfusion. And here we got in our department, we had Dr. Pradeep Reddy, who was senior in medical oncology, and he and Dr. Jyotsna, actually together they did almost 30 exchange transfusions over a period of 3 years. Although it was not the remit of a medical oncology, but we still did because we are passionate about this hematological disorder in our department. And so I'll call upon Dr. Pradeep Reddy. He's in Hyderabad. He'll actually reflect upon his experience in the previous 3 years that he was with us in same Indore. Dr. Pradeep, you please start.
Yes, sir. Good evening, sir. I'd like to thank Chitalkar sir for giving me this opportunity. A very good evening, Chitalkar sir. Sir was my guru and mentor. And yes, sir, Shivani ma'am and all my senior and colleagues. So I joined the meeting. Now I have joined passing out DM in Aurobindo. I have joined as a consultant in Continental Hospital, Hyderabad. And I've also joined as assistant professor in SVS Medical College, Mahbub Nagar. At this outset, I'm very happy to share that me, along with a surgical oncologist from Mahbub Nagar, are opening a small cancer center at my hometown, which is opening very shortly, sir.
Very good.
Yes, sir. Yes, sir. So without wasting the time, continuing from where Shivani ma'am and Swati ma'am have presented excellently and made my job very easy, I'd like to share my little experience about sickle cell disease during my stay in Indore. Since Madhya Pradesh had a largest belt of sickle cell diseases. My presentation is going to be very short, and it's primarily about crizanlizumab, L-glutamine, and stem cell transplant are still very expensive. Red cell exchange was very easy to perform, and many of our patients are like, we brought many of our patients out of the crisis at my DM time. We have performed around like 20 to 40 procedures on 60 patients. So I'll share my experience very quickly without wasting much time. We already know that sickle cell disease can present as homozygous or heterozygous. In either of the case, HBS can be more than 50%. So the mainstay of treatment remains either transfusion or hydroxyurea, but each modality has its own complications. So the rationale for transfusion, 4 mechanisms contribute to the benefit of blood transfusion. It is either by dilution of HBS containing RBCs, by addition of HBA containing red cells from the blood, and suppression of erythropoietin release caused by the rise in hemoglobin, thereby reducing the production of new HBS containing cells, decrease in percentage of HBS containing cells due to longer circulating lifespan of HBA containing cells, and increase in hemoglobin oxygen saturation levels by approximately 1 to 6%, which increases the oxygen delivery to the tissues. So, however, the potential benefit of transfusion therapy must be weighed against the potential risk as well. So, the risk carried usually will be like transfusion reactions, blood-borne viral infections, iron overload, and alloimmunization if a patient is planned for transplant later on. So, the risks and benefits should be weighed when you're planning for transfusion. Either it might be a simple transfusion or exchange transfusion. So how to transfuse? The transfusion can be a simple transfusion or an exchange transfusion. The aim of transfusions will be to increase the oxygen carrying capacity, to decrease the proportion of HBS relative to HBA, to prevent or reverse the complications of vaso-occlusion. So comparison of transfusion methods, I just want to highlight 2 important things here comparing to simple transfusion, whether it might be manual exchange transfusion or automated red cell exchange. Here with simple transfusion, the risk of hyperviscosity with high HB targets. But if you see the manual exchange transfusion, the hyperviscosity symptoms or manifestations will be less. And with simple transfusion, there will be a poor control of HBS. And with manual transfusion or with automated transfusion, you get a better control of HBS percentage. So this is a diagrammatic representation. So it's already Shivani ma'am has explained. When your transfusion should not be the mainstay, you should always see the hematocrit. When there is a rise in hematocrit, there will be increased oxygen transport or increased oxygen delivery, but the increased viscosity, but there will be decreased oxygen transport. So you need to balance these things when you are taking a decision to transfuse at the time of crisis. So transfusion should be limited and it should be very cautious. So reducing the HbS percentage, it has been already mentioned by Shivani ma'am. The goal is the HbS percentage should be kept below 30% in individuals with homozygous sickle cell mutation. So in contrast to simple blood transfusion given at the time of uncomplicated vaso-occlusive pain episode, has not been demonstrated to hasten the recovery despite the chronic baseline anemia seen in sickle cell disease. So transfusion at any point is always not transfusion need not to be a the treatment of choice always. You should be very cautious in selecting the treatment modality. So indications of transfusion, it can be, this has been already covered by Shivani ma'am and Swati ma'am. It can be either therapeutic or prophylactic. So acute therapeutic transfusions can be like for acute stroke, acute chest syndrome, and acute multi-organ failure, and acute symptomatic anemia. A drop in baseline reticulocyte count. This indicates decreased red cell production, most commonly associated with parvovirus B19 infection, but however, it can occur with any sort of infection. So hepatic or splenic sequestration, which has been already dealt by Swati ma'am. Prophylactic transfusions, if a patient is undergoing surgery, perioperative complications can be reduced by doing prophylactic transfusions, maintaining HbA around 10 gram per deciliter. So perioperative transfusions is a standard of care in children and adults with sickle cell anemia undergoing surgery that requires anesthesia for more than 30 minutes. Support for this comes from a trial called as TAPS trial. The TAPS is transfusion alternative preoperatively in sickle cell disease trial. Compared to no transfusion, those patients who have received preoperative transfusion had fewer serious adverse events, fewer episodes of acute chest syndrome, and more transfusion requirements. So when you are planning for any surgery like hip replacement for AVN, so transfusions or extensive transfusion before the procedure will reduce the side effects and length of hospital stay, was the conclusion of this trial. So prophylactic transfusions can be done for other indications like stroke, silent cerebral infarcts in children with HbS, sickle cell disease, or beta thalassemia, sickle thal patients, recurrent acute chest syndrome despite hydroxyurea therapy in severely affected individuals, vaso-occlusive pain episodes that are severe, frequent, and not responding to maximum tolerated dose of hydroxyurea, recurrent priapism, pulmonary hypertension with progressive clinical symptoms, and pregnancy. So technical aspects, when performing regularly scheduled transfusions to reduce the complications of sickle cell disease, preference is to use the extensive transfusion therapy rather than simple blood transfusion to limit the iron accumulation from transfusions. For most of the patients, the goal of regularly scheduled transfusion is to maintain the percentage of HbS less than 30% and the total hemoglobin more than 9 gram per deciliter. So indications, we had 3 to 4 patients who had presented with crisis in pregnant females. So we have successfully attempted to finish red cell exchange, and patients were thereby finished their term pregnancy and delivered healthy babies. So the indications are twin pregnancies, acute anemia, acute chest syndrome, repeated pain crisis during pregnancy, women who are on transfusion regimen before pregnancy for primary or secondary stroke prevention, or for prevention of severe disease complications. So what was our experience? This was a retrospective study conducted in our hospital from 2015 to 19 on 60 patients with sickle cell disease. The study analyzed clinical presentation at the time of admission, pattern of sickle cell disease by HPLC, with main focus on clinical outcomes, effectiveness, and challenges of red cell exchange on patients in sickle cell crisis during the study period. So manual exchange transfusion was used to perform the red cell exchange in patients presented in sickle cell crisis. The pre-therapeutic assessment was clinical examination, blood count with peripheral smear, retic count, blood group determination, hemoglobin electrophoresis, serology of HIV, HbS, AG, hepatitis C and syphilis, liver function test, kidney function test, serum electrolytes, calcium and magnesium, USG abdomen, chest X-ray, transcranial Doppler. As ma'am has indicated, transcranial Doppler is useful in identifying patients at risk for stroke. This measures the velocity in the blood vessels in the arteries at the level of brain. X-ray bilateral hip joints, family screening, cross match of 8 to 12 units of packed cells were arranged for each patient depending upon the weight of the patient. Red cell exchange procedure, Swati ma'am has indicated, calculated exchange volume is ideal for about like, if it is like 1.6 times the red cell volume. Red cell volume is hematocrit into total blood volume. For the patient more than 20 kg, it is assumed to be blood volume is 70 cc per kg, and for less than 20 kg, it is assumed to be 85 cc per kg. So there are like complex protocols, but our protocol was, we used to bleed 500 cc, and then we used to remove 500 cc and infuse with 500 cc of saline initially, then bleed another 500 cc, and then infuse 2 units of packed red blood cells. The first and second step will be repeated until the volume of packed cells administered is equal to the planned exchange volume, that is 1.5 times the red cell volume. So evaluation of efficacy was 3 main symptoms are evaluated, like bony pain in painful vasoclasic crisis, chest pain, dyspnea, and oxygen saturation in severe acute chest syndrome, paralysis, alteration of consciousness, and convulsions in stroke, painful erection in priapism, size reduction in leg ulcers. The regression of symptoms was considered as complete when they disappeared within 4 hours after red cell exchange for acute priapism, 1 day for recurrent priapism, 3 days for painful vaso-occlusive crisis and severe acute chest syndrome, and 1 month for leg ulcers. Blood count and Hb electrophoresis was repeated after each red cell exchange procedure. Statistical data analysis was done by using SPSS. Descriptive data was conducted by calculating frequencies and proportions for qualitative variables. And patient characteristics, out of total 60 patients, male is to female ratio is 1.5. Mean age of presentation was 27. Most of our patients were very young. Most common presentation was acute painful crisis. 12 patients out of 16 had palpable splenomegaly, again correlating with the patient HB genotype, that is sickle cell type of genotype. This is again a cartoon showing presentation. Acute painful episode was the most common presentation. We had 3 patients presented in pregnancy with acute painful crisis. Distribution of patient genotypes: 48 patients were of sickle cell disease, and 12 patients were of sickle cell type. So the mean HbS value was 66% for 60 patients. Except the bilateral hip joints of 3 patients showed features of avascular necrosis of femur. 10 out of 60 patients presented with pulmonary crisis, and chest X-ray showed pulmonary infiltrates in 7 and pulmonary infarction in 3. 3 patients had gallstones and altered liver function tests. So 3 patients in pregnancy presented in bony crisis, pulmonary crisis, and were diagnosed as new cases of sickle cell disease. 2 patients presented with convulsions, and MRI brain was suggestive of cortical vein thrombosis. So red cell exchange was done in 20 patients out of 60 presented with various acute complications of sickle cell disease, including acute bony crisis, avascular necrosis, pregnancy, cortical venous thrombosis. So this was the oxygen saturation levels. Patient presented with acute chest syndrome. If the HbS percentage is 65, the saturation levels were around 70 to 60. And when after exchange transfusion, if HbS was targeted below 30, or target was below 30, where you can see the saturation levels were about more than 90%. So the mean HbS value post red cell exchange was 12%. So sorry for the values here, which the baseline, the mean value was 66 for HbS percentage for patients admitted with sickle cell crisis, but after red cell exchange, the mean value was 12, and correlating with HbA values, the patients admitted with painful crisis at baseline, it was 3.5. Post exchange transfusion, it was about 80%. So post red cell exchange, patients were discharged on hydroxyurea. Hydroxyurea was prescribed at a dose of 15 mg per kg, monitoring the parameters like hemoglobin, platelet count, and absolute neutrophil count. So this is again the real data, which I have data of 2 patients. 1 patient presented with avascular necrosis of femur, showing HbS percentage. Here, HbS percentage of 24.7 at baseline with HbA value of 62. This was the value before exchange transfusion. We have proceeded for exchange transfusion since the patient was planned for procedure. Post exchange transfusion, the value of HbS was 0%. This was again HbS value of a pregnant female presented with a history of 2 abortions. You can see the HbS value of 71% post exchange transfusion. After immediately after red cell exchange, the HbS value was 0%. So this work shows that given despite low resource rating, manual exchange transfusion can be safely and successfully performed in management of several complications of sickle cell disease. About safety, a low rate of minor acute adverse events are occurred. Indeed, during red cell exchange, acute complications are usually rare and usually transitory. Majority of the complications which we have observed were electrolyte disturbances. Red cell exchange with hydroxyurea does more than simply raise the hemoglobin level for oxygen delivery. Transfusion also lowers further the percentage of sickle cell hemoglobin and increases the hemoglobin oxygen saturation, both of which decrease the propensity again for the vasoocclusion. The use of hydroxyurea is mainstay in overall management since it reduces the incidence of hemolysis and prolongs the survival. Conclusion, red cell exchange is safe and clinically effective procedure with minimal or no side effects when initiated at right time by trained personnel. The main challenges in performing red cell exchange in developing countries are lack of awareness, technical expertise, infrastructure, early identification of disease condition, limited supply of safe blood. These things make RC limitedly available to many needy patients across the country. Thank you, sir.
Thank you very much, Pradeep. I think you showed some real world data.
Yes,
and yeah, exchange transfusion. All I must say is that actually tides over a crisis, and we know that we are Madhya Pradesh is underserved in the nutritional and physical the physiognomic characteristics of individuals in the younger age group is really below par as compared to the rest of the country, and we have large number of sickle cell patients. And in those, when they come in crisis, the right thing perhaps to do is to do an exchange transfusion, buy some time, educate them about hydroxyurea, penicillin, fluids, and prevention of vasoclasic crisis. And then some of them, we must screen the family completely. And then maybe with our transplant programs kicking in, the government schemes like Ayushman Bharat, etc., at some stage or the other, we will be able to even transplant some individuals. And now I will come to the next and final part of the program, which actually has got to do with recent advances, which Swati discussed very briefly. It's about crizanlizumab as to how to prevent or delay vaso-occlusive crisis. So I'll take your permission and share my screen. So what we want to do right now in the next 20 minutes is to discuss a little bit about the recent therapies, which Swati had already alluded to. And the whole idea is to prevent or delay or minimize the severity of vaso-occlusive crisis. And I will kind of dwell upon the pathophysiology of it a little bit, the pivotal studies which have led to the approval of the selective antibodies, and from there the best part of the program is at the end, which is a question and answer session where I would like the physicians and pediatricians working in the periphery actually to discuss this thing. Got Dr. Chopra from Jhabua and Dr. Gaurav Tripathi from Riva. They are there, and they'll definitely discuss the actual field experiences as they occur in the community, in the two ends of Madhya Pradesh where sickle cell disease is common. So the role of selectins and multicellular adhesions is that P-selectin gets expressed on platelets and endothelial cells. The E-selectin, however, is rapidly induced by inflammatory cytokines. And the L-selectin is then expressed on all granulocytes and monocytes and on most lymphocytes. So as the blood flows in the system, these selectins actually participate in adhesions, rolling, and capture of blood cells. Because rolling of WBCs and RBCs is considered a natural phenomenon, and the selectins, in a sense, they actually they help this process. What is the role of P-selectin in the mechanism of action of crizanlizumab? Well, P-selectin is a cell adhesion molecule. While there's a rolling of platelets and along the endothelial cells, the normal erythrocytes do not adhere to the endothelial cells, and therefore the problem is too strongly or in substantial quantities, because they are not known to bear selectin ligands or to bind to P-selectin. So Sorry. Yeah. So P-selectin inhibition in mouse models, in the animal studies, they showed that they increase leukocyte rolling and decrease adherence. So with the inhibition of P-selectins, they found that the WBCs were able to roll more easily, and there was decreased adherence to the endothelium. Then P-selectin inhibition also in mice showed that decreased RBC adhesions, that increased RBC flow velocity. So that is what needs to be done in a sickle cell crisis. Activated P-selectin binds leukocyte selecting the receptor and PSGL1-like receptor in the sickle cells. And as you can see, the normal red blood cells then are able to adhere. The cell-cell interaction should be multicellular and results in the formation of a vaso-occlusive clot, leading to pain, hemolytic anemia, organ injury, and early mortality. So what again is the action of crizanlizumab? It's a humanized monoclonal antibody. It binds to P-selectin and blocks its interaction with its ligands, including P-selectin glycoprotein ligand 1 and 2. And you can see that with high affinity, it has a high affinity for human P-selectin. And and the molecular weight is almost 150,000 Daltons. So it has two arms along with a hinge, a variable heavy chain and a variable light chain. And there's a germline framework which determines the limbs of the crizanlizumab molecule. So in the chronic pro-inflammatory state, like in sickle cell disease, the P-selectin is upregulated and overexpressed. And the P-selectin is also a key player in multicellular adhesion involving in the vaso-occlusive crisis. And blocking P-selectin selecting function may prevent vaso-occlusion and improve blood flow. The humanized antibody that binds P-selectin with high affinity and specificity blocks its ability to bind its receptors. And the long-term administration of a P-selectin blocking agent has the potential to improve blood flow and avert acute veno-occlusive crisis in patients with sickle cell disease. This is not the first and the only molecule. There have been many molecules. Rivipancel, there have been cevuparin. There's even been attempts of using low-dose unfractionated heparin, almost as little as 10 to 12 times lower the dose. It means typically you're giving 5,000 units of unfractionated heparin. You give as little as say 40 to 50 units of unfractionated heparin. And they can also block P-selectin, but that blocking does not last for too long. Then pentosan polysulfate. So like that, there have been many molecules which have been tried as a P-selectin inhibitor. But finally, this molecule, the humanized antibody has proved to be the best and the most efficacious P-selectin inhibitor. So the SUSTAIN study was the pivotal study which ultimately led to the approval of crizanlizumab for the prevention of pain crisis in sickle cell disease. And we will now briefly discuss the elements of the phase 2 SUSTAIN study. The objective was a phase 2 multicentral randomized placebo-controlled double-blind 1-year study to assess the safety and efficacy of crizanlizumab. Subjects were 16 to 65-year-old, and the diagnosis had to be sickle cell disease, either HBSS, HBSC, HBsBO, or HBsB plus thalassemia or other genotypes. At least 2 to 10 vaso-occlusive crises should have occurred prior to the enrollment in the previous 1 year. Patients with using hydroxyurea were eligible, provided they had been using it for at least 6 months. Exclusion criteria for patients on long-term transfusion therapy. The definition of vaso-occlusive crisis was an acute episode of pain with no medically determined cause other than a vaso-occlusive event that requires a medical facility visit or a treatment with oral parenteral narcotics or parenteral non-steroidal anti-inflammatory drugs, or acute chest syndrome or hepatic sequestration, as Dr. Swati and Dr. Shivani have discussed, splenic sequestration or priapism. They were also considered vaso-occlusive crisis. This was a randomized double-blind placebo-controlled trial, 198 patients, and stratification factors were whether there were 2 to 4 vaso-occlusive crises or there were more than 5 or up to 10 vaso-occlusive crises, and already whether the patient has already received hydroxyurea or not. The 2 arms or 3 arms are crizanlizumab 5 mg per kg, crizanlizumab 2.5 milligram per kg, and a placebo. The primary efficacy endpoint was annual rate of vaso-occlusive crisis leading to a healthcare visit or adjudicated by an independent crisis review committee. And a key secondary endpoint was annual rates of days of hospitalization. The three arms were actually equally well balanced in terms of age, gender, ethnicity, race, sickle cell disease phenotype, hydroxyurea use, and even the number of crises. The significant reduction in vaso-occlusive crisis with crizanlizumab actually occurred in the dose of 5 milligram per kg, not 10 milligram per kg. When the number of crises with a placebo were nearly 3 per year in that year, with crizanlizumab 2.5 milligram per kg, it was 2 per year, whereas with crizanlizumab 5 milligram per kg, it was down to 1.6 crises. So statistically significant and clinically meaningful reduction in vaso-occlusive crisis leading to a healthcare visit, confirmed by supplementary analysis by varying populations and management of dropouts. Whereas the lower dose crizanlizumab actually resulted in only a third reduction of vaso-occlusive crisis, and which is not statistically significant. So dose response was also considered likely. In addition, the vaso-occlusive crisis leading to healthcare visits actually dropped by concomitant hydroxyurea, also by number of crises in the previous 12 months, also by sickle cell disease genotypes. More than 1/3 of the patients were vaso-occlusive crisis free in the first 1 year, rather during this follow-up period of the study. More than 1/3 treated with crizanlizumab did not experience any VOC requiring a healthcare visit. There was a threefold delay in the time to first vaso-occlusive crisis and a twofold delay in time to a second vaso-occlusive crisis. So that was also very significant. Then annual rate days of hospitalization came down by almost 40% when the dose of 5 milligram per kg were used. Then, so 45% reduction in the number of vaso-occlusive crises. More than a third of patients had no vaso-occlusive crisis for more than a year, and 42% reduction in days of hospitalization per year, and delayed time to first vaso-occlusive crisis by more than 3 times. So it was the efficacy was well established, and the tolerance also, any adverse event was actually minimum. In the placebo, there were a large number, whereas in crizanlizumab, there was down by about 12%. So it was a fairly well tolerated drug. And the major toxicity was only about nausea, back pain, pyrexia, arthralgia, abdominal pain, diarrhea, pruritus, and vomiting, out of which the most significant was nausea, back pain, pyrexia, and arthralgia. Majority of the adverse reactions were mild to moderate. There was no increase in rates of infection, though there is a theoretical risk of reduction in leukocytes and therefore increase in the rate of infection. Blood count results and blood chemistry were similar to that of the placebo, and only 2 patients discontinued the treatment due to some adverse reactions. And the dosage administration was first week, second week, followed by the 4th week, and then the 6th week and the 10th week. So week 0, week 2, and every 4 weeks thereafter. And a short 30-minute infusion, and depending upon the body weight, it works. It's a 100 milligram in 10 ml vial. So a typical adult of 75 kg will actually require 3.75 vials of crizanlizumab. So a significant reduction in the frequency of vaso-occlusive disease was proven in the SUSTAIN trial, which led to the approval of crizanlizumab as another agent. And what is interesting is that in the same calendar year, hydroxyurea also was approved for the treatment of vaso-occlusive, rather the routine management of sickle cell disease. And in the same calendar year, 2017, after the SUSTAIN study, the US FDA actually approved crizanlizumab also. An increased likelihood of being VOC event-free over a period of 1 year was definitely predicated on the use of crizanlizumab, and a delay in time to first and second VOC. An incidence of adverse events and serious adverse events was similar between crizanlizumab and placebo. Crizanlizumab meets an endpoint unmet medical need, therefore, in the sickle cell patients through the reduction of vaso-occlusive disease, thereby potentially modifying the course of the disease in the future. So I will stop here, but I will also mention certain caveats. Well, the cost is significant. Availability is it's now already marketed in India by Novartis. Applicability is there, and I think it needs to be tested in a large population like the state of Madhya Pradesh, where out of 52 districts, almost 20 districts are endemic with high number of homozygous states for sickle cell disease. A fraction of patients are actually needing it because we know that majority do very well with the routine measures as discussed by the previous speakers. And the guidelines are already written up now at the ICMR as persons above 16 years may be given crizanlizumab if the hydroxyurea is failing for more than 6 months. And at the end of, as a summary presentation, I'll only say that it's a new kid on the block. We need to use it wisely and perhaps integrate it. Also look at transplant options, because I think a year's treatment of crizanlizumab is going to be roughly the same cost of, say, 5 to 6 lakhs, which in a very small child with the government schemes and some good support, we may be able to transplant small children. When we come to above 16, transplants become more and more expensive. And always there's a big problem. There's a problem of 4 to 5 children in the family, out of which 1 or 2 are actually already succumbed by the time they seek medical attention for sickle cell. So we need to go to the community, do school-based programs, good college-based programs, do family and community programs. And for that, I'm going to now turn to the two, in the question answer session, to the two stalwarts in the periphery of Madhya Pradesh, that is Jhabua and Rewa. Jhabua in the southwest of Indore and Rewa is deep northeast of Indore. And I'll welcome the, firstly, I'll first make it open to the house and first invite any questions, burning questions from anybody in the audience. It'd be a pleasure to, for any one of the speakers, I'm sure. Any quick question from the audience before we have a formal question and answer session?
Good evening, sir.
Good evening.
Yeah, I'm Dr. Narendra from IMS Bhopal.
Yes.
Yeah, can I have some questions?
Yeah, of course, some questions, and then we'll of course have a formal question.
Yeah, first of all, thank you so much for arranging this meeting. This is actually, I am face to face, I'm talking to you first time, though we spoke on phone many times.
Oh, yes.
And it is nice to meet Madhya Pradesh people at one this especially for the problem where it is common in Madhya Pradesh only. Okay, my question regarding crizanlizumab is that it is one thing is it is very costly. Initially, Novartis came with the patient support program, but I think they have stopped. Yeah. So, are you getting any support for this crizanlizumab, because it is costly, about 17,000 rupees per vial? Yes. And for one person, usually the dose comes, because it is actually indicated 16 above, so dose usually 3 vials or more. Yeah. So do you get any support from anywhere, like even Ayushman or any other scheme?
No, it's actually not had experience, and I know that the patient support program is about to end. So yes,
it's already ended. In October it is ended.
Yeah. And I know that in a year's time it will cost them at least 6-7 lakh rupees. 1 year's stock for 3 to 4 vials per dose, it will cost about 6 lakhs to 7 lakhs.
Yeah, so it is actually for 1 year, it is equal to the transplant.
Yeah, exactly.
Even transplant can be done.
Yeah, exactly. Yeah. And that's what I was coming to. So you're absolutely right. So do you have experience in All India Institute in Bhopal?
No, among the new drugs, we have experience with L-glutamine. I don't know whether it is pharmacological grade or not, but there is one sachet of L-glutamine is available, which is 10 gram per sachet. 10 gram or 15 gram, I think. And so that we tried in 2 patients, and we got a modest response. Over about 1 year they have used, and it was we experienced the decrease in their pain episodes. For pain episode only we have given, but again it is difficult to sustain regular therapy, because it is also not so cheap. they will have about 250 rupees per day cost.
Yeah.
So that also they cannot afford.
I agree.
So they have stopped after that.
Yeah. And I must.
Transplantation I have not used because we deal with pediatric patients and 16 above. We did not have any eligible patient at the time of when program was on.
Absolutely. Yeah. And I think what you need to put in perspective is, the different modalities. You said glutamine, very right. Crizanlizumab, expense, yes. Exchange transfusion also helps because the pregnant woman comes in 31 or 32nd week of pregnancy. The big issue is whether the pregnancy is going to be safe. And a lot of times she presents in some crisis or the other, some hemolytic crisis or some acute chest syndrome. So it's a good idea at that stage. What we found in our experience in SAMES, almost 5 to 6, as Pradeep showed, almost half a dozen women we've done for exchange transfusion, and we were able to actually conduct the deliveries safely. So that was there. Similarly, patients coming for avascular necrosis of the femoral head, after exchange transfusion, they were able to undergo the anesthesia and the surgery very safely. Actually, absolutely uneventfully. So those are the positives of this invasive type of therapy like exchange transfusion. And I think even this has a definite role. So thank you, Narendra. I think you brought out very valid points. And I would now like to call, we'll just have a formal question answer session, and I will throw the first question to Dr. Chopra, who's a pediatrician in the government setup in Jhabua. And Dr. Chopra, welcome to this session, and please speak up and tell us about your experience in Jhabua, because you are in one of the highest endemic areas of sickle cell disease.
Thank you, sir, and good evening, sir. Good evening, sir. Sir, since 2019 से मैंने स्टार्ट किया था यहाँ पर सिकलिंग का मुझे चार्ज मिला था. दैट टाइम हमारे यहाँ ना CBC प्रॉपरली हो रहा था, और उस टाइम मुझे ये प्रॉपर जो है प्रोग्राम मुझे दिया गया, तो बड़ी मतलब उस टाइम बड़ी दिक्कतें आई थी सर कि कोई समझ ही नहीं रहा था कि सिकल को ज़्यादा सीरियसली नहीं ले रहे थे. तो पूरे फील्ड था, पूरा डिस्ट्रिक्ट था, अराउंड 10 लाख पॉपुलेशन अराउंड है हमारी, उन कवर करना था. तो इनिशियली सर हमने सिकलिंग टेस्ट स्टार्ट किया फैसिलिटी लेवल पे. सर फैसिलिटी लेवल पे जब हमने सिकलिंग स्टार्ट किया तो जो है हमारे सिकल पॉजिटिव निकलने लगे. तो अब क्या करें, सामने ये सवाल आ गया, क्योंकि उस टाइम पे इतना अवेयरनेस नहीं थी यहाँ पर. धीरे धीरे सर हमने फैसिलिटी पे फिर ANC को इन्वॉल्व किया कि अब हम साथ में इसको ANC को भी इन्वॉल्व करें. तो ANC में भी सर हमारे बहुत पॉजिटिव निकलने लगे, बट ANC को फिर हम कैसे काउंसलिंग करें, तो हस्बैंड का हमने स्टार्ट करा. अब हस्बैंड वाइफ दोनों के हमारे पॉजिटिव निकल गए, लेकिन अब सर इसके बाद में हमारा आउटकम कुछ नहीं था कि हम इनको इंदौर भेज दें. बट इंदौर तक पेशेंट जो है जाने को तैयार नहीं था कि हम इसका CVS करवा ले, जो रनिंग प्रेगनेंसी में कि आने वाले बच्चे की क्या रिजल्ट रहेगा. नाउ अब जो है जब से ये प्रोग्राम लॉन्च हुआ है अभी हमारा, तब से हम लोगों ने कर रहे हैं, सिकलिंग कर रहे हैं, इलेक्ट्रोफोरेसिस हम लोग करने लगे हैं. तो अब जो है सर थोड़ा सा हमको रिजल्ट मिल रहा है कि हाँ अब सही दिशा में हम लोग जा रहे हैं. बट इनिशियली 2 साल सर हमने बहुत ज्यादा सफर किया इस चीज को लेके.
आई रिमेम्बर मैंने आपसे बात की थी, तब आप पॉलीक्लिनिक रादर वो डे केयर एस्टैब्लिश करने के स्थिति में थे, फिर वो पैंडेमिक हो गया.
नहीं सर, डे केयर हमने सर एस्टेब्लिश कर लिया सर यहाँ पर. बट सर डे केयर में भी सर अब प्रॉब्लम ये आ रही है कि सर VOC वाले जो बच्चा जो हमारे पास आ रहा है, अब सर हम उसको डे केयर में तो रख नहीं पा रहा सर. एक दिन में उसका सर VOC कंप्लीट हो नहीं, मतलब केयर हो नहीं पा रहा. तो सर डे केयर भी सर हमारा सक्सेस नहीं है.
तो क्या आउटकम क्या है, मतलब उनको क्या आप इंदौर भेज देते हो फिर गवर्नमेंट?
नहीं सर, हम पीडियाट्रिक वार्ड में इसको शिफ्ट कर रहे हैं
उसके बाद
पेशेंट को, या फिर जो हमारा एडल्ट पेशेंट उसको मेल मेडिकल वार्ड में एडमिट कर रहे हैं. और सर मतलब डे केयर में सर सिकल मैनेज कर पाना बड़ा मुश्किल सर काम है.
सो आपका क्या आप नंबर्स बता सकते हैं, मतलब रफली क्या इंसिडेंस है आपका पीडियाट्रिक्स में?
पीडियाट्रिक्स का सर हमारा जी सर
OPD में क्या नंबर्स आते हैं आपके पर डे या पर मंथ या पर ईयर जैसे?
सर अराउंड सर 50%, 50%, 15% के अराउंड सर पेशेंट हमारा निकल के आ रहा है सर
अच्छा,
सिकल का।
ऐसे।
हाँ सर, जब से अभी इस प्रोग्राम का जो जब से प्रचार प्रसार हुआ है जन अभियान के माध्यम से जो है निकल के आया है, तो जो लोग थोड़े बहुत जानते हैं कि हाँ हमारे यहाँ पर फैमिली में ये समस्या थी तो हमें हमारे बच्चों को चेक कराना चाहिए, तो सर वही मेरे पास निकल के आ रहे हैं। और लगभग सर अभी हम लोगों ने कैंपेनिंग स्टार्ट करी है, तब से अराउंड 3000 के अराउंड हमने टेस्टिंग कर ली है सर, जिसमें से कम सर हमारा ये मान के चलो कि 450-500 पॉजिटिव निकल आए हैं सर।
अच्छा,
हाँ सर, तो वही 10 to 15% का रेशो सर निकल के आ रहा सर हमारा।
that's very, so मतलब that is a
हाँ
significant number actually.
जी सर, ओवरऑल सर जब हमने पुरानी स्टडी भी देखी यहाँ की, तो उसमें सर हमारा 15 से 25% का रेशो निकल के आ रहा है सर।
Okay, काफी significant है, मतलब
सिग्निफिकेंट
definitely
है।
it's, yeah.
अभी जो मेरे पास टेस्टिंग में आए हैं उसमें सर मोस्ट ऑफ केसेस में ट्रेट निकल के आए हैं सर हमारे। डिसीज कम है बट फिर भी तो जो सिकल ट्रेड है या सिकल का जो ट्रेंड है वो अराउंड 50% निकल के आ रहा सर।
अच्छा, आपको हाइड्रोक्सीयूरिया फ्रीली यूज करते हो आप? मतलब हाइड्रोक्सीयूरिया हाइड्रेशन जो
बिल्कुल सर, अभी करने लगे हैं सर हम लोग। लास्ट जब हमने 19 से पहले जब हमने सप्लाई करा था सीएससी लेवल पे, तो वो तो सर हमारा एक्सपायरी हो गया, क्योंकि डॉक्टर्स में भी जब उन्होंने यूजीपीजी के टाइम पे जो पढ़ा होगा कि हाँ हम हाइड्रोक्सीयूरिया देते हैं, बट वो हाइड्रोक्सीयूरिया उन लोगों ने यूज नहीं करी। बट अभी सर हम लोग कैंपेनिंग कर रहे हैं, ट्रेनिंग कर रहे हैं, तो हाइड्रोक्सीयूरिया अब यूज कर रहे हैं सर पेरीफेरी में। बट इनिशियली सर हमारा एक्सपायर हुआ है पेरीफेरी में सर। हाँ, जी सर।
और कोई प्रेगनेंसी में कोई एक्सपीरियंस या और कोई क्राइसिस का एक्सपीरियंस जिसको आपने मैनेज किया?
सर हमारे यहाँ गायनेकोलॉजिस्ट है, वो लोग हम लोगों को मतलब जैसे ही कोई प्रेगनेंसी पॉजिटिव आती है तो सर वो हमें इन्फॉर्म कर देते हैं, बट मैनेज वही लोग करते हैं। अभी लास्ट टाइम एक फैमिली जो है दोनों हस्बैंड वाइफ ट्रेड थे सर, तो उन लोगों ने अब अवेयरनेस आई है तो वो लोगों को हमने सर इंदौर सीवीएस के लिए भेजा है सर अभी।
ऐसे।
जी जी सर।
थैंक यू वेरी मच। एंड हम आपको एक आधा क्वेश्चन और भी पूछेंगे जैसे जैसे चर्चा आगे होती है।
बिल्कुल बिल्कुल सर।
So now what I would like from Shivani is, have you had experience of transplant in your previous institutions, and how does it work? You know, and whom do you select?
So I think the transplant, as I said, the very specific indication, and I think in India, if we see majority of the transplant centers who are doing transplant for sickle cell, they are doing mostly for international patients, and hardly Indian children they do require. So if they are on a good hydroxyurea therapy, they are compliant, there are very minimal indications we actually have to go for transplant, and I think that is what the I'll enforce here is ki we have to have a prevent approach here.
Yes.
More and more people on hydroxyurea, more and more people who are doing their routine follow-up, routine test and all to detect early organ damage, because majority of them they do well on hydroxyurea. There are very few percentage who are not responding or have inadequate response with the hydroxyurea therapy.
Yeah, that's true. I mean, but do they tolerate transplant conditioning and all that as good as? I mean, what is the data like in the?
So actually, whatever patient I have seen is again they were international patients. They were not Indian phenotype, and more or less they do tolerate transplantation as like they do with thalassemia major patients.
Yeah, that's true. And what are the other? I mean, what do you think should be the strategies in the periphery, in the districts which have got heavy, like he said, such a high incidence? What should be the strategy? How do you reach families with sickle cell phenotype?
So this again, everything as Dr. Sandeep also mentioned that more and more people need to be tested. It's like, you know, the first and foremost thing we should be doing in our country, like we know our blood group, we should know our hemoglobin electrophoresis status, what it is. So there is where prevention of the disease, I think, is the best way forward, because the incidence is very, very high. You can test anyone and you will see that they are minor, either thalassemia minor or sickle trait or anything, and people are not even aware. So presenting with a report during pregnancy also is very difficult to do anything at that time, because we are so time bound at that time कि उसी time CVS करना है, उसी time report भी चाहिए, and then we have to take a decision of MTP before 20 weeks. We are all very crunched during that time. So more and more people before marriage, before pregnancy, should be made aware to know that this is the status, and that I think the stigma should be removed, and this is all only possible through public awareness.
Absolutely.
So this is regarding prevention, and as Dr. Sandeep mentioned, doing an excellent job there. We do get people from Jabua and all. They know that they have disease, but they are not being following up or not on the maintenance therapy. So more and more people, if they know that what the disease causes and how they can be normal if they are doing routine follow-up and taking just popping a pill once a day, and it's just like any chronic disease which can be managed. I think that will help more at a community level.
आपने डॉक्टर चोपड़ा, आपने मेरे साथ डिस्कशन में बात की थी, प्लानिंग नाउ स्कूल बेस्ड प्रोग्राम्स.
बिल्कुल बिल्कुल सर. वी स्टार्टेड स्कूल, मतलब सभी स्कूलों को सर हम लोग टेस्टिंग स्टार्ट कर रहे हैं सर अभी, जिसमें सर हम लोगों ने 6 मंथ टू 18 ईयर तक के बच्चों को कवर करना है, जिसमें हम लोग आंगनवाड़ी को कवर करेंगे, प्लस एवरी स्कूल सर. टोटल सर हम लोगों का टारगेट अराउंड 4.5 लाख बच्चों को टारगेट करना है सर.
ओके.
हाँ, तो टोटल सर हमारी पॉपुलेशन जो है इतनी 4.5 लाख पॉपुलेशन है जिसको हम कवर करेंगे. जो और साथ में सर ANC का लगभग हमारा 1.5 लाख पॉपुलेशन हमारी ANC की है, जिनको हम कवर करेंगे सर.
परफेक्ट. सो हम लोग इस दिशा में जा रहे हैं धीरे धीरे. हमारे सेम्स में भी वी आर प्लानिंग अ प्रोग्राम, एंड मे बी विल गेट इन टच विद यू वंस अगेन, बिकॉज हम लोग चाह रहे हैं कि इस प्रकार का प्रोग्राम वेल इक्विप्ड इंस्टीट्यूशन शुड डू, नॉट ओनली द गवर्नमेंट बट द प्राइवेट आल्सो.
जी जी.
क्योंकि हमारे पास सारे ऑल द फैसिलिटीज आर देयर, एंड मींस पीडियाट्रिक डिपार्टमेंट इज डेवलपिंग वेल, हेमाटोलॉजी इज वेल, एंड ऑल सपोर्ट सिस्टम्स, ब्लड बैंक. सो मतलब ये जो एक नोडल सेंटर के रूप में हम चाह रहे हैं कि अपने आप को, जैसे आप एपिडेमियोलॉजी के लिए ऑलरेडी द नोडल सेंटर, राइट?
बिल्कुल बिल्कुल सर.
तो आप क्या अलीराजपुर भी कवर करते हैं आप?
नहीं सर, अलीराजपुर भी अलग एक टारगेट है सर. वहाँ भी नोडल ऑफिसर है डॉक्टर पटेल.
अच्छा.
हाँ, तो वहाँ भी सर हमारा अराउंड यही 3.5-4 लाख का पॉपुलेशन को हमको कवर करना है सर वहाँ भी.
अच्छा अच्छा.
जी सर.
अच्छा. सो और ये
सेम
क्वाइट राइट. अच्छा
जी. सभी को सर हम सोलिबिलिटी टेस्ट करेंगे.
ओके.
हाँ सर, सोलिबिलिटी टेस्ट में जो हमारे पॉजिटिव आएंगे दैट ए टाइम सर हम लोग उनका एक सैंपल रिसीव करेंगे वहां से, और वो सैंपल सर हम लोग डिस्ट्रिक्ट में लेके आएंगे.
अच्छा.
यहाँ पर सर हम लोग जो है इसका HB इलेक्ट्रोफोरेसिस करेंगे सर. HB इलेक्ट्रोफोरेसिस आने के बाद में सर जेनेटिक काउंसलिंग कार्ड फिर हम उसको प्रोवाइड करेंगे. अगर मान लो वो ट्रेट है तो हम उसका ट्रेट मेंशन करेंगे, अगर डिसीज है तो हम डिसीज मेंशन करेंगे. अभी जो सर सिकल का ये जो काउंसलिंग कार्ड, जो हम लोग को जेनेटिक काउंसलिंग कार्ड जो इन्होंने डिजाइन किया है सर, वो वेरी नाइस सर. मतलब उसमें उसका डिजाइन ऐसा है कि सर अगर हम बॉयज का एक अलग रहेगा, गर्ल्स का अलग रहेगा, तो अगर दोनों कार्ड को हम सर मिला के उसको काउंसलिंग करेंगे तो परसेंटेज ऑफ कि आने वाली पीढ़ी में आपका कितना परसेंटेज बेबी सिकल रहेगा या ट्रेट रहेगा या आपका नॉर्मल रहेगा, वो परसेंटेज रहेगा. और पीछे सर हमने बड़ा इजी तरीके से उसमें मेंशन किया है कि आपको शादी करना चाहिए या नहीं करना चाहिए.
ओके.
तो वो एक जेनेटिक काउंसलिंग कार्ड बड़ा इजीली किसी को भी समझ में आ जाए ऐसा वो मेंशन किया है. मतलब उस तरह से प्लान किया है सर. वो आपको मैं सर शेयर करूंगा सर उसे.
आई थिंक व्हाट्सएप पे शेयर कीजिए.
बिल्कुल मैं शेयर करूंगा सर. हमें
दैट विल बी गुड
है ना. वो काउंसलिंग कार्ड सर हम फिर यहाँ से जन अभियान परिषद के थ्रू हम लोग उस जो अपना पेशेंट है वहां तक पहुंचाएंगे सर उसको, साथ में उसके पेरेंट्स को काउंसलिंग करेंगे सर।
Very good. Dr.
जी
Swati,
जी
any
सर।
questions? Dr. Swati, does this bring any new questions to your mind?
Sir, I heard what Dr. Chopra said, and it is a very commendable effort on his part, and it is really appreciable that he's doing it at school level. That is the best place to detect sickle cell anemia, to diagnose sickle cell anemia, and to prevent further complications.
Yeah.
And when there is such high prevalence in his community, it is a really good effort to do it at ANC level also. And
Yeah.
hopefully with frequent and with good number of screening, we'll be able to at least eliminate the diseases. May not be the sickle traits. Sickle traits might still persist, but at least the diseases we might be able to eliminate from our community.
Absolutely.
So a very appreciable effort.
And why? I mean, the question always remains like, why are we interested in sickle cell when we talk about teenage and young adult cancer? Well, the problems of sickle cell and problems of young people's cancer is actually almost identical. I mean, they also undergo the process of partnership, marriage, childbirth, post childbirth, and all the problems which are there in the young people's cancer are also common to sickle cell. And plus, it's a very treatable disease. It is not as I mean, nobody needs to die of sickle cell as we can. I mean, the message that, if a layman's message I want to send, I'll say that, well, it's a very treatable disease. And unlike, I mean, it's so much better than even thalassemia for that matter, because there is no ferritin accumulation, there is no organ dysfunction. There is organ dysfunction, but it's of a different pathophysiology, and it's very preventable. Just like in thalassemia, also it's preventable. So, so these are the things where we are on the fringes of our specialities, and we need to cross our boundaries and go across and actually look at it. That is the way forward, because there is no point working in silos. I mean, your doors have to be open for all these indications. Because you'll not, in our country, still we don't need to be super specialists. We need to be a little open to other diseases, other patients with other disorders, and actually use your science and use your social entrepreneurship also. And that's what we are trying to do. And that is also the spirit of bringing this group together. So thank you very, very much. I think Dr. Gaurav Tripathi is online. Am I right?
Yes.
Dr. Gaurav? So I think I saw him coming in, and then anyway. But that would be nice actually. He was in working in Riva, and he got about 6-7 years experience over there, and that's another completely different world. Again, the same state of.
हमारी बहुत
Yeah.
सर से बहुत सारी बातें हो रही थी, वो शेयर करते रहते हैं हम लोग.
Absolutely.
डाटा शेयर करते रहते सर के साथ, हेल्प होती रहती है सर जी.
And one failing of our today's evening has been that we not got people from Chhattisgarh, because I don't think we can talk of sickle cell without actually including doctors from Chhattisgarh. So I'm sure whenever we organize it next, I'm sure I'd like to involve doctors from Chhattisgarh, because that makes it complete. Madhya Pradesh and Chhattisgarh together, I think, account for probably most of the patients of sickle cell in our country. A part of it is a little bit in Gujarat also, right? Bordering Madhya Pradesh, there are some districts of Gujarat which are also affected.
दाहोद और फिर राजस्थान के बांसवाड़ा, डूंगरपुर, ये मोस्ट ऑफ केसेस जो है अफेक्टेड एरिया है सर.
Yes, so this is that. And there are pockets in, you'll be interested to know, there are pockets in Jammu and Kashmir also, very small pockets for some reason. I don't know the ethnic reason, but they are there. So this is practically the map of sickle cell map of India. ये 3 states, Gujarat आपने कहा, Madhya Pradesh, Chhattisgarh, and all. So any other questions from anybody? I'll welcome before we conclude. And anything missing from my side, please point out so we can improve.
No, sir. If any advice, sir, मतलब सर हम लोगों को आपकी कोई advice सर बताएं सर.
I think you're doing a great job, and we need to learn from you. We should be able to multiply. We should be a force multiplier. If you got 450 positives in 3,000 patients, I can imagine how many more you'll collect when you target all the 450,000 children that you are planning to target, and also the antenatal care of 150,000 women. So when you do that, you will be definitely huge data you'll get, and you need to organize the data well, present it in different forums, present it in the hematology conference. We can invite you, the Indian Society of Hematology and Transfusion Medicine. You should actually present that through the government. And
अभी सर हम लोगों का
also
प्लान है सर, अभी सर हम लोगों का प्लान है कि गायनेकोलॉजिस्ट को सर हम लोग ट्रेनिंग के लिए भेजें कि वो सीवीएस
हाँ,
और इनके लिए सर हम प्लानिंग कर रहे हैं सर।
absolutely, absolutely.
जी,
And,
तो उसके लिए सर हमें इंदौर रेफर नहीं करना पड़ेगा, फिर
absolutely.
एंटीनेटल केयर के लिए सर हम यहीं प्लान कर रहे हैं सर अभी।
बिल्कुल सही, बिल्कुल सही.
जी।
Everything should be local. And
जी सर।
yeah, I mean, it's a huge population, and if you cover it, and I mean, you'll have an improved healthcare in about 20 years time. You have to work for 20 years, I can tell you. And but the only thing is, you must try to reach every sibling in the family. I see that a lot of, you can't reach every sibling. It's very, very difficult at times. They don't show interest, and a lot of heterozygotes and all that, they don't come. They're just normal, but they need to be tested at some stage, because there are implications in terms of marriage and future children and all that. So I think that counseling we should do in schools. Schools is the
सर
best.
इसमें सर हम लोगों ने ये प्लान भी किया है कि सर हम नेगेटिव को भी कार्ड देंगे सर।
Yeah.
तो नेगेटिव, पॉजिटिव एंड ट्रेट तीनों को सर हम देंगे।
बहुत बढ़िया, बहुत बढ़िया. I think that will be a big thing. And so please do
जो
share. आपका कार्ड जो है शेयर कीजिए WhatsApp पे, और हम
जी
लोग
सर मैं व्हाट्सएप कर दूंगा। बिल्कुल बिल्कुल सर।
with your kind permission, and I'm sure we will do something. Yeah.
ओके सर।
Thank you so much, everybody, for joining and spending your Saturday evening. Yeah, and I'm sure we can do something positive and take it forward.
ओके,
Thank you so much,
थैंक यू
Narendra.
सर।
Thank you, sir.
Yeah,
थैंक यू सर।
Swati, everybody. Yeah. Thank you so much.